all of us doing together, and we're recording now. It's also a real privilege last night to spend time with all the families, listen to their stories, watch Warwick eat 10 cupcakes with the paper, and meet the pun master, Parker. And I want to acknowledge, as an ICU person and as a researcher, that in your questions, which are excellent, by the way, questions I would hope my Harvard trainees would be able to ask, I hear the hope in your voice. I also hear the desperation, because the clock is ticking, and that's lost on us. We understand that. We're working to understand that we're with you on that journey. And I want you to know that we acknowledge that that is what you're feeling. And we want to partner with you as intensivists, as specialists, and as researchers. It's also been a privilege to work, and an honor to work with Warren and Dixie and their incredible child, Raceland, for the last 5 years, from pretty much day one until now. And we were even talking about him at home, making sure he doesn't come to the unit. It's been wonderful to see. He's one of my top 10 graduates of the PICU, a child I was really concerned for. That's not a merit badge you necessarily want, but spending holidays and weekends, birthdays in the PICU, again, is not a merit badge you intended to achieve, but we've all done it together. And I think I've spent 100+ hours at the bedside, and we have long conversations, not just about critical care, but about longitudinal concepts. And it's always been a privilege to be invited to the conversations that involve all of Raceland's care providers outside of the ICU, because a lot of what we think of doing next might eventually land him in the ICU. So being part of that conversation is great. And Patty, Dr. Mussolino, and Lindsay we're in early conversations about when we get to the point of gene therapy, we probably will start in the ICU setting, and having that and being prepared for that. And we've already gone through that with other disease states at this institution and preparing for that. So I'll go through a few slides. I think what I've learned really here, and what we'll present, is more what we've learned in our experience with Raceland, and informed by what others are speaking about today. And I'm really looking forward to hearing from Dr. Hauska and Schnell about their incredible work with ACTA-2 patients. Okay, got it. This institution requires that I state conflicts of interest. I'm a co-founder of a small respiratory device company. We try to monitor work of breathing in children. This is not a technology that's launched yet. And then we have several patents out of our lab under the late Warren Zapel, and some are licensed out, but I won't discuss those in this forum, but I just have to disclose them. So you've all seen the literature, and it's gaining momentum, and there's more and more. There's that published are definitely Dr. Hauska pretty soon. I don't need to tell you where smooth muscles are, but because they involve not those smooth muscles, because they're everywhere, and this is what you've discovered as families, and for a lot of you, the fact that smooth muscles are involved in the eye, or in the sweat glands, or in areas where there's piloerections or goosebumps, were sort of the early hints, right? So something was odd, and you're trying to convince someone that something was wrong, which is something we hear in the ICU after lots has happened. And unfortunately, we've had the opportunity to meet you. But because smooth muscles are basically everywhere, and smooth muscles govern various physiologies, my group, my team, which is a multidisciplinary team in the ICU, we are involved in multiple, intervene on basically every level, right? So you all have specialists that probably fit almost every single one of these categories that you try to coordinate and see Unfortunately, it probably happens where you have to see them individually, but we'd love to coordinate it all at the same time. And the area that we're really good at, well, let me go back. In these various organ-based situations or contexts, I tell my trainees that it's our job after 6, 10, 15 years of training that you have to have the knowledge and expertise of about 50% of our consulting colleagues. I will never pretend to know what my gastroenterology colleagues know completely, but I've got to know a good chunk, because at 2 a.m, I have to make a decision with my team about a critically ill child who's crashing right now, right? So we have to have a good understanding of what's happening with their cardiac system, what's happening with their pulmonary system, et cetera. But the area that we're really experts at is pulmonology or pulmonary or respiratory mechanics, and how it intersects with technology. So like mechanical ventilators, et cetera. So and not all ACTA2 children there's a range, right, of how the lungs are involved, but smooth muscles actually govern how those mechanics work. And there are various respiratory interventions that should help, but don't always help. And so what we've learned through Raceland and conversations is that, we see a mixture of chronic lung disease. It's sort of mixed, both restricted and obstructive. And then, of course, an acute exacerbation is usually what lands the child in the ICU setting. We, for a while, used this concept of a single alveoli. We're made up of millions of alveolar spaces that exchange gas. In a full-grown adult, it's about the size, it's about 1,000 square meters, which is like the size of a one-bedroom apartment around here, probably about like this, or about half this. That's a lot of surface area, but when they're younger, children don't have that. And a lot of children with ACTA2, a lot of those alveolar spaces just have not formed, or they act like they're not participating in appropriately in gas exchange. And that's what we see. And so we almost saw physiology where instead of having millions of these, just little pockets that were working or not working in gas exchange. So we tended to use sort of moderate ventilatory support, use moderate driving pressures, and moderate PEEP or positive end expiratory pressures. We found that if we did too much, we went backwards, et cetera. And your team, your respective ICU team, should be able to tailor the respiratory support to your child, and that changes over time, and it requires constant vigilance, et cetera. We're trying to use moderate FiO2. We've learned that a lot of children do well, even if their SATs drop a little bit, they'll come back up over time. And then think about pulmonary arterial exacerbations, or even extracardiac shunts, right? That is, especially when a child is unwell, we see a lot of hypoxia without a lot of X-ray evidence of lung collapse. And so we've used bronchodilators and like albuterol. And sometimes it leads to an improvement and sometimes it doesn't. And this is something we actually see in asthma quite often, that if we use a bronchodilator, a lot of times in the very beginning, we see a worsening VQ, ventilation perfusion mismatch, and the child desaturates. And then there's a phenomenon called pulmonary or hypoxic pulmonary vasoconstriction, which we study in our lab, that is a response to an area of an alveolar space that's not working very well. So the oxygen content in that area is low. The blood vessels tend to constrict in that area and push the blood to areas that are working. But that mechanism does not always work, and it requires constriction, which we all know these children struggle with. Also takes days to recover, right? We don't have like 24-hour visits to the ICU. A lot of you have like the week, month badges, and we tend to carry very slow wean on support. We've learned not to say, well, look, they're better. Let's just crack everything down to normal levels overnight. That's usually not encouraged. And then, of course, airway considerations with ENT over time. But I think maybe a common theme here is always requesting a huddle. Come bringing your team together, whether it's just the ICU team or all their consultants, to say, look, something's wrong. Can we tell you what we've experienced with our child thus far at this institution or other institutions? Let's talk, because My child has not read the playbook, which I'm sure you've all experienced. And I don't know what the playbook is. And a lot of children don't follow the playbook. And so your team should be able to pivot with you and your child. Okay. If you mechanically ventilate a child, you have to sedate the child. If you've ever tried to put a ventilator to your own mouth, which we have the trainees do, and I've seen them get hypoxic because they fight it. A child needs to be sedated to some degree. So some of the things we've learned is dexmedetomidine or Precedex. We've seen severe bradycardia. That's something we see in most children, but we've seen really severe bradycardia. That's to the point where we try to avoid it in Raceland sometimes. Fentanyl is difficult to wean off, so we try not to go back to it. Propofol, I've only seen this once in my career. Raceland did it, where we gave him propofol as a drip, and he got more awake, more active with propofol, which I have never seen before. But this is another theme, is that even though that was something we actually put on Epic on his chart to avoid, we have since utilized it for procedural sedation, and it works. And so I am always happy when a child proves me wrong in a good way. And very slow weans on Versed and Valium and methadone are things that we've experienced so far. And as Dr. Mussolino spoke about, with regards to vascular autoregulation and cerebral vascular autoregulation and how it works, it's really good for us to think about what we're doing at the bedside will manifest as some shift in how well the blood is perfusing the brain, and whether to utilize monitoring systems, which our lab is talking with different companies about how to do that best, EEG, near-infrared spectroscopy, et cetera, or avoid deep sedation if we can, which I'm sure all of you are very concerned about when someone says, let's just do an MRI, or let's just do this procedure real quick. Timeout, this means massive sedation. This means the sedation and a potential of staying in the hospital for, instead of just an hour-long procedure, for a few days. And so sometimes we'll work to think out of the box and work to host a procedure at the bedside and not have to travel and do a prolonged sedation. Further challenges, and this is something Dixie and I have been talking about for Raceland, is that if someone thinks, let's do a quick sedation, just put them to sleep, let's just put the SP tube in or a PICC line in real quick, timeout, let's have a huddle, let's think about what happened last time, let's make sure the PEEP is maybe even higher on the ventilator, or at least give them some ventilatory support, because these children tend to collapse very quickly. They don't have the tone to keep their lungs open. And so let's be a little bit generous, and let's think about that so that we can get them out of sedation faster and not just try to say, well, they'll handle it. No, let's try to conserve what we call the functional residual capacity of their lungs, their FRC, keep their lungs open, et cetera. And we've noticed that some children, Raceland for some reason had a trend last year with every little procedure. He would come in for about an hour and he would land in the PICU for 2 weeks. And some of it was PEEP loss, probably from transporting and not having the tone as of an awake child. You saw him yesterday with his wiggles on the video. He's breathing quite well, but if you sedate him, he loses that tone and he sort of decompensates. So we've been talking about considerations in that context, and maybe even a pulse of steroids. We also noticed for some reason he'd have a hyperinflammatory reaction afterwards. It was kind of a little bit bizarre. So we started talking about using NSAIDs, but we have to weigh that against kidney disease, et cetera, which we talked about quite a bit yesterday with Dr. Tan. Vascular access. No one likes to have their child poked. It's one thing to have yourself poked, but to watch your child suffer through not one poke, but many of you have probably used the term pincushion. This is ridiculous, but we need to get access. We have to think about the trauma to the child versus the IV versus placing a PICC line and having the possibility of a DVT and a thrombus and the complications thereafter. So we talked about that quite often, and sometimes it's justified and sometimes we can push the pause button and just wait. And it's always good to think about, which Dr. Hauska will talk about, I think the downstream effects of all the things that we do might have some deleterious effects, but we hope that the risk and benefit reward is balanced in the favor of the child always, right? So muscle relaxation, that's an issue, right? That takes a while for those children to generate the strength back. So if we can avoid it, we'd like to, but if it's absolutely necessary, to have a conversation. Talk about cerebrovascular autoregulation, like we talked about, maintaining a decent pH and CO2. The cerebral vasculature is exquisitely sensitive to how the level of CO2 in your blood. And we can try to alter that on the ventilator using the minute ventilation. And then be mindful of vascular events, insufficiencies within the vasculature itself. And talk about CNS monitoring, which we talked about earlier, just to see if there's a way for us to maintain surveillance while a child is asleep. And then, of course, look for latent end organ effects. I talked to my team about anticipatory guidance overnight tonight. This is what I want you to think about. If you think this child's fine, don't ever say that in the ICU. Just sort of think that something is going to go wrong. So this organ system, this organ system, this organ system, and be ready. And always balancing recovery and convalescence, necessary interventions, and then decompensations due to trigger events. So one thing I do talk to my team about is considering the sort of the sphere of care. As intensivists, we tend to think about mitochondria, cells, tissues, organs, but it's a lot more than that. How we impact those specific areas is really impacted by the room, by the team, by the hospital, and by the institution and the community itself. And it's good to think about the reverberations that occur inside and outside of the child. And it's not just the child in that particular context, it's what happens the next day. It's what happens when they go home, and to be part of that ongoing conversation, even as an ICU guy. So maybe some questions to consider. Who's your advocate? You're all your child's advocate, but who's your advocate maybe outside of your family? And I think this is not for you necessarily because you know how to listen to yourselves, but we impress upon our team, especially my young trainees who say like, I'm a second-year medical student or I'm a second-year resident, which is all well and good, but you just don't know medicine yet. I'm sorry. But you know who does? The mom or the dad. So you better listen up. So if mom says, this is not what she did last time, you should be starting to shake. You got to get concerned. Something's wrong. And I'm hoping we're all proven wrong and the child does something different, again, to their benefit, but be wary, right? So if this is not her, last time they did this, or I'd prefer it if you consider it this way. This is not the time to put your stake in the ground and say, I know aptitude. No one is allowed to say that these days, right? Not yet. And I think it's important to have a conversation with all of you who are the consummate expert in your child's health. And then we recognize that a lot. And if you're not getting that tone or that signal from the ICU team, ask for the next level up. That's understood. Who's your camp counselor? We talk about, meaning who's the advocate, who's bringing you all together. Here we are. I think this is very much like that. Here's what the global advocacy. Who's the director? I like to think of that is who's the director in your camp? Is it you? Is it a central coordinator? I like to also, when I work with research teams, to talk about storyboarding. And it can be as simple as when the child arrives at the hospital and we have to do a PICC line placement, can we just literally talk about getting out of the car, going to the elevator, getting to the in-service areas where anesthesia meets us? Where do we go next? That narrative is tricky, and a lot of things can happen along the way, and it's important to talk about that. When we are going to talk about gene therapy, we're going to storyboard this out from left to right. How do we walk through this intervention? What do we anticipate? And all the variabilities. Or we can think about like huddling. Do you huddle with a team in the ICU setting? Do you huddle with a team before? Are you guys involved before a major procedure, et cetera? And what does that look like? And who's your quarterback? Sorry, he's very confused. I can't follow what he's doing. But who's the voice? Is it you? Do you have a central care coordinator that's the voice that you trust And then in our ICU team or in our care team, who is that on the medical side? And I think that's what's unique in this multidisciplinary approach is there's multiple providers. Do they all have to meet at the same time? I think with Zoom and the acceptance of Zoom and working no longer physically apart actually probably has enhanced our ability to do that. And I think that's been great. But I'm just advocating that the team members always involve the family. There have been novel therapies that we've used. These are old therapies that we've repurposed for ACTA-2. And I think emphasizing early preparation is important, discussing the history, listening to the family say, look, you may not have been here last time we did this, but this is what happened. And talk about and anticipate the pathophysiology that might ensue. And really involved, the main care coordinators and huddle together. And again, we in our ICU, we have a primary nursing team. So if you're in the ICU long enough, usually you have a set of nurses that you've come across, and they sign up to be that child's primary team. A lot of times you can request, or actually the charge nurse will actually anticipate as that child is being admitted to try to keep the same nurses who know that child the best. That's not always possible, but look, I would advocate it for it. If you think that's something, if you know a few nurses that know your child well, say, is it possible that X, Y, Z can be on my team while we're here? Just so you're not explaining and every single time, every single day. And that's okay, ask. And it's a little bit different for the physicians because we rotate so often, but I think it's okay to ask, look, I'm getting a lot of mixed signals. I'm getting the attendings have changed every 5 days and it's driving us nuts. Can we talk to either the chief or someone we consider to be a consistent person involved in our child's care to weigh in? So sometimes when we have family meetings, even though I'm not on service, we'll meet together, et cetera, or whomever. I think taking care of these children requires, any chronic care child requires a lot of innovation. And who's your inventor? Who's thinking out of the box? So in the early days for Raceland, he had a lot of light sensitivity. I kid you not, he looked like this. We put the bonnet on him because he was. We put the glasses on him because there was just too much light. The room is dark. That he doesn't need that anymore. The lights are on. He's quite awake. Noise was a problem, so we really tried to put signage that said "Be quiet around this room" as much as we can in an ICU. And tactile stimulation was something he needs, but also we needed to avoid surprising him and setting him off. So we think about these things. He gets warm, so we have fans that disappeared for a while. Biomed didn't like the fact that there were fans that they hadn't regulated, but I think we've stolen them or found them. And if you need a fan, it's in his room. Tactile and auditory stimulation, think about special body wraps because of his Eagle Barrett. We talked about his prune belly. As he was starting to try to move around, it wasn't fair because his abdomen just sort of accumulates on his two sides and he can't move. So we created a special taco for him so he could roll. And the model guys, a lot of hospitals have guys that like to make models and orthotics. And you just got to find them, and they get really excited. They really nerd it out and say they just start to. The whole team will show up and say, what do you want us to make? We'll make it, whatever it is." They get really excited. So hopefully you have that. I think child life is essential. I think Raceland, just as soon as someone the other day said even the word music, he sat up and just sort of said, "Okay, bring it. Where are they?" I took it, and he loves to participate. And I think it's also important to make sure that they're interacted with within reason and not overstimulate those children. So these are my overall thoughts. Maintain an open mind, think out of the box, not just for you, but for the providers. Don't journey alone. I think that's part of this process is to work together, journey together. For my team, I often said you have to listen to the families. They have the greatest amount of experience, expertise, and patient-specific data. Coordinate and try to huddle before major moves if you can, and keep track of patient-specific reactions. So either families are really good at listing these things, but it's hard to produce that paper every time when you come in. It should be an Epic, but it's not always. So if you need some historical data, either get a care provider or a nurse that knows the child. or be at the bedside yourselves, which I'm sure you've done. And then we were just talking about in Epic, we do have a care coordination plan that I'm not allowed to enter into the chart until I click that I've seen it. And that's something that you can put in place. But we've also talked about the fact that that's non-transferable to other systems. And then we talked about really identify who's your advocate and your innovators, et cetera, to help you move forward with your children, and go slow and be flexible. I think there's something that we've noticed is that a lot of things that apply to Raceland may not apply to the next child, or they might, and that's why we want to share our experiences. The other is that what applied to him when he was 2 and 3 really kind of don't apply now, like the propofol story. He kind of likes it now. And so think, after a little bit of time, maybe something that didn't work, ask why it didn't work. And, if it really risked their lives, then we probably shall never use it again. But if it was something that was moderately effective, or there was a slight side effect, maybe reconsider it. So be a little bit flexible. So that's all I have. The other questions were around. So thanks very much for the opportunity.